Hi everyone, welcome and thank you for joining us for today's ASA web seminar, Hospital to Home, Dementia Capable Care Transitions, Better Care, Better Outcomes, which is part of the National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living. We'll be getting started shortly. The slides for today's presentation are available under the tab on your screen marked Resources. And under the tab marked CE Application here, you'll find information on how to obtain CE credit for this event. You'll have 60 days to complete a continuing education application, and it may take up to 30 days from the date of your application in order for us to process and issue your CE credit. If you are not logged in directly to this web seminar, that is if you are watching as part of a group and did not log in using an individual confirmation URL, you will not be eligible for continuing education credit because we have no way to track your online attendance. If you'd like to receive CE credit, please be sure you log in using the confirmation URL you received after individually registering. If you have questions during the presentation, you can send those at any time using the questions box, and we'll save those for the last 10 to 15 minutes of today's program. And now I'd like to welcome Sari Schumann of the National Alzheimer's and Dementia Resource Center. Welcome, Sari.
Thank you so much, Betsy, and thank you to everyone today for joining us for the webinar Hospital to Home, Dementia Capable Care Transitions, Better Care, Better Outcomes. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi everyone. Wanted to just thank you very much for joining us today to learn about the Hospital to Home program. Jeff Klein is a great grantee of ACL, and we're excited to share all the excellent work that the Nevada Senior Services has been doing. So with that, I'm going to give you back to Sari so we can get started. Thanks.
Thank you, Erin. And as you heard, today's presenter is Jeff Klein. Through Jeff's almost 50-year career, he has been an innovative, visionary healthcare, aging services, executive, and consultant. He is currently President and CEO of Nevada Senior Services, operating adult daycare, in-home respite, home modifications, geriatric assessment clinic, and wellness programs. Nevada Senior Services is the Aging and Disability Resource Center for Southern Nevada. Mr. Klein chairs the Nevada Commission on Aging Legislative Subcommittee and is an active member of the Public Policy Committees of the American Society on Aging. At this time, I'll turn the presentation over to Jeff Klein so he can share his wisdom about hospital to home and dementia-capable care transitions. Jeff?
Thank you, and it's nice to hear your voice, Sari and Erin. And it's nice to be with all of you, in this time of so much social isolation, to be with a group this large, even though I can't see all your faces, is very exciting and warming. So hospital home, to give you a frame of reference, we'll take a minute and talk a little bit about Nevada Senior Services. You heard most of it from Sari and Erin, and then talk a little bit about the environment in which we grew this program up into, and then we'll spend most of our time focusing on the intervention itself, the outcomes, and I hope I'll have time for a little bit of the secret sauce that has made us successful as we go along. So as we mentioned, we're kind of a broad-based senior services agency for most of Southern Nevada, and some of our evidence-based programs are actually statewide. And the frame of reference we always have is, what can we do to help people successfully navigate life and stay home? So it's all about avoiding institutionalization, supporting participants, supporting family caregivers, and operating in an environment that is quickly becoming a real challenge from an aging perspective. As many of you know, Nevada is one of the fastest growing aging communities in the whole country. Depending on whose numbers and whether you want to look at actuals or percentages, we're either number one or number two in the aging space for growth in aging. And our caregiving environment is particularly challenging because so many of our homes that have family caregiving going on are really non-nuclear. The children or other family members are in other parts of the country instead of in Nevada. And that creates distance challenging, which I know is not unique to Nevada, but is a particular problem that we have. dementia is clearly one of the largest challenges we have in the entire state, and the percentage increase not only of dementia but of the things that are impacted by dementia in Nevada are just astounding. So it's the sixth leading cause of death in the state. We've had a 261% increase in deaths from dementia-related disease since 2000. And it's becoming more and more part of the fabric in which both community-based organizations and healthcare organizations are operating in. And it's made even a little bit more challenging because we have a geriatrician shortage, as we do nationally. But geriatrics tends to be a fundamental factor in how successful we are in our hospital environments. If there are geriatricians floating around doing consults, we see a very different culture from those hospitals that lack primary care, and particularly the geriatric community. So it's a challenge. So, as everyone knows, dementia represents a particularly challenging set of issues in the community writ large, but particularly in the healthcare community. And so it increases the impact of problems of all other kinds on our acute care systems. It's frequently invisible, and we'll be talking about that in a minute a little bit more, to the hospitals and to the emergency departments. It creates excessive resource consumption because folks who are more vulnerable and require higher levels of communication and require more interaction with family caregivers, particularly in this COVID-19, create an enormous burden on the floor staff and the clinical staff of our hospitals in trying to respond to an environment with the patient that they're very uncomfortable with. Folks with dementia have higher complication rates and, to our point, have much poorer outcomes. Dementia is more likely to create hospitalizations, and folks with dementia are less likely to be observed in the hospital because their record does not reflect the dementia. And one of the things about medications that's really important, that's part of the secret sauce of identifying folks with dementia who may not have it in their record, is to look to the medications chart and see if they have one of the 5 primary dementia drugs in the chart. Hospitals are just absolutely unaware very often that they have somebody with the dementia in their bed. So to them, a cholecystectomy is a cholecystectomy, and a 72-year-old person with a gallbladder problem is a 72-year-old person with a gallbladder problem. But if they have a dementia and they're not aware of it, then many of the other complications that go on as a result of that flow from that lack of sensitivity to the issue. We know that folks with Alzheimer's disease in particular tend to be more frequently hospitalized, and that their family caregivers also tend to be more frequently hospitalized. And studies have shown, and I frankly think we're lowballing here, that dementia compromises as much as 40% of total 30-day readmits. I suspect it's much higher than that, and particularly in our post-COVID-19 world. And to make matters just a little more difficult, hospital patients with dementia just don't bounce back. Now, seniors, as we all know, have a more difficult time bouncing back in general. The older and more fragile they are, the more difficult bouncing back from a hospitalization becomes. But with this population, we're more likely to see decline in the hospital and then a lack of bouncing back, particularly, again, magnified in our post-COVID world, where there's even less support in the home environment for solutions that create contact with the outside world. Social isolation takes over, and we end up with folks coming out of the hospital damaged by that experience cognitively and unable to get their access to the resources they need in order to get supported and bouncing back, while their caregivers continue to deal with depression, and the ability to navigate multiple organizations trying to impact them, which it's one social worker and one doctor and one nurse too many for many of these caregivers who are so fried. So we know that many of these folks are going to be discharged to a nursing home, either because the caregiver can't tolerate it anymore, or more likely the hospital needs to get them out of a bed, and that's a safe place to send them. So the other issue is that the short-term placement in a nursing home is less likely to occur. These folks are more likely, once they get into a nursing home, to still be there 3 months, 4 months, 5 months later, and may never get out. So with that confluence of problems, the big idea, and that was to create an evidence-based, dementia-capable care transitions model that would be really rooted in the culture of the community and be a culture changer and be a support system for both the participant and the family caregiver. And our goals initially, as we identified them, were to find that evidence-based care transitions model for post-care transition services, but frame it within a community-based dementia-capable framework. And that's really important. Knowing that it's community-based and integrated so that it is not another one of those post-acute hospital services that's designed to have a short-term impact and then goes away with no shelf life. A second objective was to initiate a new modality of support, and we call that respite coaching. We'll be taking a few minutes to talk about it a little more, but it is really an intensive process to support the family caregiver, to give them a break, a hiatus in the action, while at the same time providing them education, supports, and connectivity to long-term services and supports. And finally, we recognized we needed to change both the culture and the level of knowledge in the healthcare community as well as in the family caregiver community. So creating a stream of dementia-capable education and training where we could go into the hospital, try to educate the staff about dementia, about Alzheimer's disease, and also to help the care partners become better navigators. And this has been a very interesting part of the journey. So it started when Nevada Aging and Disability Services Division said to us, gee, we have this opportunity for a small pilot program inside one of our grants. Would you be willing to take on the creation of an evidence-based vehicle for hospital home care transitions for the dementia space? And being an old hospital administrator, I said, sure, I know how to do that. We had CMS care transitions models, and we'll just pick one of those up and we'll implement it in Nevada, and then we'll disseminate it. And lo and behold, we found there was none. Something I should have remembered, but I didn't. And so we went on a hunt and to see if we couldn't find a baseline vehicle that we could then adapt for our purpose. And we did that. We're going to be looking at that model and how it's evolved in a moment. Having done that, we were very blessed to receive as a follow-on initiative a grant from the Administration for Community Living for Hospital2Home to evolve it, develop it, implement it, test it, play with it. And this would be a good moment for me to just say that for those of you who have not had the experience of working with ACL on one of these grants, it's been a very pleasant journey. The level of planning on the front end that's supported by the grant, the amount of thought process and support that goes in, the questions that get asked, all have significantly contributed to the outcomes that we have. And that is just so rare, where so often it's get a grant on May 15th and have it up and running, seeing clients on July 1 with no breathing space to evolve the programmatic. So this has been a wonderful journey, and my hat's off always to ACL and to Aaron and the folks at RTI and all the help we've received. So that grant targeted multiple levels of population. So we started looking at who's in the hospital's bucket. And so we focused on folks with both diagnosed or self-identified dementias of any age. We also looked at the issue of folks who are at high risk for ADRD, including individuals with developmental disabilities as a special target area. They had to be hospitalized for any medical condition. So they could be that gallbladder with a dementia. And we also were looking for people living at home alone. And that's become a very important part of our initiative because it represents really unique challenges to the healthcare providers in terms of how do they successfully and safely discharge one of these folks at the end of the acute portion of the stay. As I mentioned, when we started the journey, we did not have a natural vehicle. So we had to put together a team to think about how we would do this. And so one of the things about the secret sauce to the success of the program was that we built a team that could help us have perspective as we move forward. And so we went out and we got an old colleague, the folks at Cognitive Solutions, to provide outside knowledgeable independent thinking as we went through the journey to help us evaluate different care transitions models and to ask critical questions. And then we built an internal team which included Jane Gruner, who is just a wonderful member of our family, who was a long-term executive with the state of Nevada and had been the administrator for the Aging and Disability Services Division. And having that outside-inside voice who could help us not only with nitty-gritty planning, but to help us ask critical questions and challenge our thought process has really been part of the secret sauce. And I think having that person on the team for anyone as you go through an innovation initiative is really important. Somebody with that skill set. Then we have to find a committed partner. And in our case, we were very fortunate to find the Valley Health System with its 7 hospitals. And within that group, their Regional Director of Care Management, Gina Parati-Bootman, who has been a passionate champion of this program from the day we conceived it through implementation and continues this day. And that's really important, having a healthcare partner who is committed to the concept, who sees the vision, and is willing to take on the internal issues that occur in every hospital when you hear things like, my nurses are too busy to do this, or my care managers are too overwhelmed to do that, or our IT system doesn't support this. All those kinds of natural, cultural, and operational roadblocks come up. They come up frequently. They never go away. And having an internal champion is really an important aspect of success. And having them on board from day one and framing the model was really important. And lastly, we decided on Bridge, originally developed by Rush University Medical Center as that core evidence-based tool that we could build around. We felt it worked extremely well with our social work orientation. It integrated well with our community-based programs, but also we felt tied very well to the hospital model. And so it was a good fit for us, and working with the team there was just a joy. They're folks we've known for years, and so it made for a natural collaboration and became the core. And so we actually built much of our program around that model and then kind of expanded what we use bolt-ons so that we didn't break the model, but we were able to add all the elements that we felt were so important to create a model that could be replicated, that was dementia-friendly for the community, that would integrate well with the hospitals, and could be used with other frameworks going forward in replicating it. So the collaboration with the hospitals, the work with Rush, and then finally the decision to really focus on wraparound services in the early phases of how we deliver the intervention is really important. So needless to say, the post-care transitions model has to be very person-centered, and in this instance, it's like the cavalry arriving every day when we get a new case. And so it's figuring out where the cracks and pressures and valves are that need to be addressed as a person moves from the hospital into their home environment, and there are both pragmatic and practical things that occur, and then there are longer-term planning things that occur. And just to give you an example, on the practical side, we had a discharge where the person was going home to an environment that had no refrigerator, no food, no place to store medications, where the family member with dementia had as a family caregiver a person who was on dialysis, home dialysis. And so into that challenging first day environment, we have to get a refrigerator, we have to get food, we have to get medications, we have to get medical support into the home, we have to deal with the dialysis issues that the family caregiver had, and with an enormous amount of psychosocial pain, while trying to tease out what were the objectives and values that went beyond the Maslow's set of things to those things that would create long-term impact on the ability for this family to settle into a life of independence. And finally, finding a way to create internal and external referrals for ongoing supports in a way that could be managed by the family caregiver and didn't contribute to that overwhelming sense of, I just can't take one more thing. So the bridge model, person-centered, social work-led, as I say, fits us to a T, and we think has been very good as a natural vehicle for this program. But it's not exclusively the only way one can go, but it is a very natural frame. But other care transitions models can be inserted, if you will, into the center of this, as long as their values are consistent with the way you want to deliver the program. The bridge model emphasizes collaboration, which is every bit what this program requires, and it has the ability to incorporate enhancements of other evidence-based dementia education tools, which we used as bolt-ons. And so we have a whole series of other evidence-based vehicles that we use for training, that we use for educating the respite team, family caregiver, and the healthcare people. And finally, integration of those enhancements is really an incredibly important aspect of the whole initiative. So when one looks at the workflow, simply, we were designed to start at the identification of a potential person with a dementia in a hospital bed. And that, as I mentioned, can be a real challenge. And so having the care management team of the hospital on board and aware is really very, very important. Second, having people in the hospital. So we credentialed our people to actually be team members in the hospitals who can go around and talk to the nurses on the nursing stations and actually look at the electronic medical record. So having people credentialed so they could get to client identification and to the bedside was really important. In our COVID world, that's become significantly more complicated. And so we tend to get people later. They tend to get discharged sometimes faster. And so sometimes we have a bump. And if we can't get to them quite soon enough in the hospital, we actually pick them up often in a subacute setting as they move into that environment or on discharge to homes. But we try to get at them as early in the process as we can. As we begin to develop responses to initial problems, I mentioned the refrigerator, the medications issues, and so on, the team starts working on multiple levels. So the social workers are problem identifying, behavior identifying, creating plans. The respite workers are creating space for the family caregiver and the participant to function in and to decompress and to begin to learn how to manage in their environment, which could be skill sets, like managing behaviors for the participant, or starting to tie into the earliest steps of long-term services and supports. Another aspect of the workflow is to promote engagement by the family caregiver and care participant, and that's become really important aspect and one that we've been very successful with. And ultimately, post-discharge, program runs for 30 days. We're looking at how do we tie it into longer-term services supports and what kinds of results that we want to have. And we'll talk a little bit in the outcome section about this at length, but clearly we wanted to decrease readmissions. We want to decrease emergency department visits. We want to enhance or improve the patient and the caregiver's stress burden, the desire to institutionalize them, and we want to decrease mortality. To make all of this work was quite a challenge, and we had to start looking at what aspects we could manage internally as part of our process, and being the Aging and Disability Resource Center for Southern Nevada really helped because we had a lot of things at our fingertip, but not everything. And so we had to look at what supportive programs could we connect to in the community, what could we evolve, what evidence-based tools could we use from our collection of resources, and how do we bring that to bear as a program impacts caregiver after caregiver and family after family. The external piece, like the hospital piece, required us to start out early to develop a community set of relationships. So we started looking at this whole concept of stakeholders, and in the first year we had our first stakeholder conference, and we had about 19 agencies that we started to work with, and you'll see as we get a little later on the way that grew, but the importance of having an active stakeholder set of relationships became clearer and clearer to us over time, not only in terms of being able to create resources for our families and our participants in the community, but in terms of case identification, problem identification, how to access resources that might otherwise not be available. I'll give you one of my favorite stories tonight. We had an early case where it looked like the person was going to get tossed out of their apartment. We were told by the county at the time, gee, sorry, when they get tossed out, call us, but until then we can't do anything. But because of our stakeholder connectivity, we were able to get to somebody in the county who said, no, we think we can help you. Let's figure out a pathway forward, and we were able to keep them in their home. That comes from stakeholder engagement. It comes from having developed deep community roots where you can pick up a phone and access somebody who can help you, with the idea that you're not trying to solve the broad community issue. You have a participant with a specific set of issues that you need to resolve today. It is action today. And hospital to home always implies action today. The longer-term services and supports will come as things evolve, but there are always the crisis of the day and that need to be resolved in the now. The short-term respite coaches have been just an enormous part of the secret sauce. So think about them as super CNAs, getting into the home as soon as discharge occurs. These folks get 80, 90 hours of additional training beyond what you would expect, and we use evidence-based tools as one set, and then our own education and training models, shadowing and coaching. And one of the other items in the secret sauce is making sure you have a leader in the program who sees their role in part as being the chief coach, the manager and chief coach. So we're always looking at constant, continuous improvement in how we deliver situations in terms of support, in terms of developing the skill set of the respite coach and the skill set of the family caregivers, and that requires a real unique set of skills. And we've been blessed to have Betty Russell, who's an LCSW, lead that team for us, and that is in her DNA. And I suggest for anyone who wants to look at how to create an effective hospital home team, that top person needs to be very person-centered, participant and caregiver-oriented, but also needs to be a coach and a manager and a support system for the team, and particularly the respite coaches. As I mentioned, we started to deal with education and training, and one of the things that Cognitive Solutions developed for us was Thoughtful Hospitalizations, which is a 90-minute workshop for caregivers that helps them prepare for navigating the hospital environment, both from emergency department to inpatient and post-acute admission perspectives, how to ask questions, how to be a personal advocate, and then thinking about thinking, which is also something that the folks at Cognitive Solutions helped us develop, and that we have delivered together with them in hospital settings in different formats. It's been a whole day seminar for those who are willing to bring their chief clinical people and nursing people and administrative people together for a day. It's been a half-hour program. We've broken it up into shorter bites. But the whole idea is to address cognition and patients in the acute care environment to help build sensitivity and skill sets so we can identify people early, have people respond to the person with dementia more appropriately, decrease length of stay, and improve the outcomes. So it is culture change. And it's an ever-evolving process. I can't tell you we've achieved it even with Valley Health System, who's just done a great job. But it's something that is critical if we're going to make long-term community change. And then on the perspective of staff training, we utilize a whole range of resources, as I mentioned. We put them through Dealing with Dementia 4-hour workshop that was developed by the Rosalind Carter Institute, Caring for You, Caring for Me, which is a 10-hour, originally Rosalind Carter Institute developed program, and then our own versions of caregiver education programs that have been just really successful in training both the family caregivers and our team. So what kind of results have we had? So as of about a month ago, 363 people have been through the program. One of the things we did is we widened the lens because of COVID-19 to include people who are being impacted by COVID-19. And interestingly enough, the number of discrete COVID-19 cases we have that don't have cognitive implications are really quite small, because so many of our admissions have been in vulnerable seniors, so we're picking people up who had previous cognitive issues. But when we look, the population that we have entering the program very often utilize services but don't get to the point where we've done that 30-day post-evaluation. And so we have a lot of folks, and I think in an operating program you'll see this with some frequency, who are not your completers if you were doing an evidence-based trial, but did receive pretty much full services or most of the services of your program, and you can see it's been growing fairly rapidly. So here's the first major takeaway. Our readmission rate is 0. Let me say that again. Our readmission rate is 0. We have had no readmissions for the same diagnosis in 363 cases. We've only had 16 for a different DRG. So if somebody came home from that gallbladder hospitalization and they were a person with a dementia and they ended up with a readmission for a fall or a stroke, that's in the 16. Now, Southern Nevada's readmission rate overall for Medicare is 35%. So I think that number speaks for itself. Do I think it's going to stay at 0? I can't ever imagine that it would. But there is magic in the secret sauce that puts high-intensity resources into family caregiving environments in highly stressed situations, and this has been a very successful undertaking. I mentioned participating organizations when we first started out. That first year, we did our first stakeholder meeting, 19 organizations. Last February, we were at 69. Today, we're probably north of 75 or 76 agencies with which we collaborate on this program on a regular basis. Our COVID response, when we added it to the data collection in April, as I mentioned, was fascinating. So we've had 6 folks with a firm COVID diagnosis, but we've had a whole range of people who had COVID exposures, were quarantined, and socially isolated. And then another much larger group of folks without a diagnosis, but socially isolated as a result of COVID. And that too has been a fascinating part of the journey. When we look at outcomes, one of the things we monitor is what we call first-tier challenges, and that's those challenges that frequently occur in discharge. And needless to say, the issue of insufficient support at home is by far 66% of our assistances are for that reason, and I don't think that shocks any one of you. Others that are really important that come up frequently is access to community resources, confusion about discharge planning, particularly in the rapid environment this discharge planning frequently takes place in a hospital, and an unsafe physical environment. And the fact that we are able to mitigate some of those environments through our home modifications initiative has been really important to keep the home safe as a person arrives. Second-tier assistances are the problems that we encountered along the way. And educating the family caregiver and the other people in their immediate orbit about dementia has really been a difficult and important problem to impact, to see if we can't alter the perspective they have about dementia, about how it's impacting the people in their orbit, dispel misnomers. Really important. Dementia education, as we talked about. Caregiver stress, I don't think is any shock to anybody how critical that is, and based on the kind of testing we do of both the family caregiver and the care participant, the desire to institutionalize, caregiver burden, really high, really problematic, and frequently is a cause of that immediate or short-term institutionalization that can come even if there is not a discharge to a long-term care facility. And then finally, one thing that always seems to bubble up is this issue of helping people in a broad basis identify where their problems are so that the respite coaches and the social workers can help them create a plan. So referrals for support, and one of the things about the referrals for support that you should know is these are new referrals for support. So if somebody was already receiving the service, it doesn't show up in these numbers. So as an example, adult daycare is about 9%. Those are 9% new referrals. So if 20% of the people were already receiving adult daycare, it would not be in that number. These are new referrals. And I don't, again, think it's shocking to see that there's a very high demand for respite care, partly that addressed initially by our respite coaches, but usually transitioning to other forms of respite support and deep caregiver supports, psychosocial support, planning support, behavioral management supports, helping them better function in the home with the person they love so very dearly. And I often tell stories about my own experiences as a family caregiver and how I rarely brought that home, that knowledge home. You can see some of the other results we had. Zara caregiver is a pre-post, and at the 3-month mark, we've dramatic decrease in burden. So, a case study. Mother and daughter were hospitalized at the same time. I mentioned this one earlier. Daughter, who's the family caregiver, getting home dialysis 11 hours a day. Mother with severe dementia. They left against hospital advice, so they went out AMA. They were staying in a studio motel room. They got respite, long-term care. They ended up having to meet in a laundry room because it was the only private place they could find it. As our social worker tells it, they did the dance of joy, and that created a pathway moving forward. We were able to modify the environment for the wheelchair. We made some adjustments for wandering, and we focused on helping the mother and daughter communicate more effectively, and we clarified the medical coverage. At an unannounced home visit about 2 weeks later, the caregiver was slumped over in a wheelchair, hooked up to her dialysis, confused, disoriented, and feverish. We were able to get a home visiting doctor in, and the fact that we showed up was just a miracle, and we were able to save a life. And those stories are very frequent when you have the kind of high-intensity case engagement that this program has wired into it, into the DNA of the program. This notion that people care and not everyone is out to get you was really important for this family caregiver situation, but is a frequent message we get from the families. A couple of other things about the secret sauce. As I mentioned, the construction of the program wires into it a very high intensity of resource, both from the family caregiver perspective and the care participant perspective. From our perspective with the respite coach and with the social worker, it is a team of the whole. We recognize that everyone takes this journey in the company of others, but alone. And so every response, every approach, every nuance of planning is a new world, a new experience. And so it's more than patient-centered. It's this notion that if you've seen one, you've seen one. We've all used those words. I think it's just so critical to bring resources and put them at the fingertips of the people who need them and let them, to the extent that you can, direct where you need to go, to tell you where the points of pressure are. It is a total community initiative. It narrows to how you function in the healthcare environment, change it. It narrows down to that family unit, and it narrows down to continuous learning and quality improvement, program change, changing your education tools, changing the response that you create, dealing with medication issues. It just never ends. But it is one of the great blessings of the program, and we're very excited about the outcomes that we've had. We're excited about the fact that we've been able to adapt it in the COVID world to remote significant portions of our work so that we have a little less contact in the home environment, which makes many of our family caregivers feel much safer. And so we try to navigate what the comfort level is with the family caregiver and the care participant about having people come into the home, and find that balance and then evolve that relationship as it moves forward so that the respite coach and the social worker have a really good sense of what the longer-term prognosis for making change with the family caregiver is, and how to create those supports in a way that don't burden the family caregiver. And as I mentioned earlier, these folks are so fried by the time we get them that putting one more decision on them frequently can break the bank and send them screaming into the night. Next thing you know, you have a admission to a long-term care facility. So navigating that over time is just really important. One last thank you, and then I'm happy to take questions. As I mentioned, as this thing evolved, it was a team effort. Having the hospitals on board, absolutely critical. Having them have a champion inside the hospital, really critical. Having outside voices, an outside consultant in the case of Cognitive Solutions and an outside insider in the case of Jane, and having an internal champion with passion, and then being able to build on the construction of other models so you're not always reinventing the wheel. So bridge, dealing with dementia, caring for you, caring for me, all elements that we were able to incorporate, and then over time you evolve your own components that meet your needs, that are used to train your staff and help adjust the environments in which your family caregivers operate in. And finally, circling back, making it an all-community effort. So the stakeholder meetings we've had, 3 years of them, have really allowed us to evolve, get input from our community, and create new connections that then support the family caregivers and the care participants as they go through their own individual journey. So with that, I'll thank you, and I'm happy to take any questions.
Great. Thank you so much, Jeff. Great presentation. We have a lot of questions that have come in. And, you know, there's quite a few here that are asking about stakeholder involvement, how you got hospitals to agree to work with you, what other stakeholders did you have, and where did you start? I know that there were some challenges too. If you could talk a little bit about that process and how you overcame some of those hurdles, especially with the hospitals, that would be great.
Hospital's been a particular challenge, and it's probably going to be a forever challenge. One of the things that was really important that I've kind of hammered on a little bit was having an inside the hospital system champion. In this case, it was a regional director of care management. So she was able to go both to the hospital CEOs to get buy-in, and we had multiple meetings. As I said, I'm an old hospital administrator, so we had multiple meetings with hospital CEOs and COOs to get their buy-in. But Gina's constant push to get her people engaged was really important. And then utilizing the success in that environment allowed us to help recruit some others. Now, also did not hurt that the word got out to occupational therapists and social workers in the community, who then became instigators of referrals, and successful referrals breed more successful referrals. And I always say, give us the toughest case you got and let us show you what we can do. Getting doctors on board, primary care physicians, also important. So there's a lot to be said about utilizing your networks to create meeting opportunities, face-to-face, or in today's world, Zoom, to connect with healthcare providers, to get the word out, show them what you can do, and then recognize that they're not going to see the world quite the same way you do. And so you have cultural lapses, you have natural resistance to doing things certain ways, and that is a long-term cultural change.
Great, thank you so much. We also had a few questions come in asking about, I know that the program right now is being funded by the ACL grant, but a bunch of people are asking about if you are considering trying to get insurance reimbursement in the future, if you're going to move to a fee-for-service model. Do you have any insight into how you might move forward after the funding is no longer available?
Great question, and something that's actually been on our burner since day one. And I mentioned Jane Gruner. She is a constant voice of that issue, among other things, in the team, reminding us as we've gone. So where have we gone? Well, we've become a Medicare provider and are looking at how we can carve pieces of the program off and do billing to Medicare or to Medicaid or to other insurances as a provider. So for instance, the respite coaching, for instance, we believe a big hunk of it will be potentially billable to both to Medicaid, if nothing else. We think parts of the social work component, and we're looking at occupational therapy pieces that will integrate for the home assessments that we think will be billable. So we're looking to do that, and we're also looking to work with managed care organizations. This is a natural. In a 30-day cycle, you could take a potentially very expensive, very problematic, very resource-intensive case from the managed care perspective and avoid the readmission, decrease the utilization of services, and avoid a institutionalization. So we think it's a conversation to have. We think it's one where there is cost benefit as well as human benefit, and so we are looking to get very heavily engaged in contracting with the managed care community as well.
Great, thank you so much. So we also had a few questions come in asking about the screening tool you used in the hospital to identify people living with dementia, and were there any challenges to implementing that?
Hospitals have been and their systems have been a major challenge for us. So, for instance, their systems, and I don't think this is a surprise to anybody who's ever worked in a hospital, you can't find the word dementia in an ED record. So many people come in through the emergency department, it's not there. Then they get up on the unit, and if it's not a primary admitting diagnosis, it's not in their record. So the only way you know that you potentially have somebody with a dementia is the family caregiver self-identifies to the nursing station, which frequently they don't for a variety of reasons. Or the clinicians on the floor pick up that this person has been receiving one of the 5 major dementia drugs. We have been unsuccessful in getting hospitals to do screens through their IT systems of identifying folks with dementia by virtue of the drugs they're on, the medications. And so identifying folks has really been a problem. We pick them up mostly as high-risk case management identified cases, and but changing the environment where hospitals are actively searching for people with cognitive impairment, and once we get past the grant parameters per se, if you think about cognitive impairment from the hospital's perspective, that also includes people who might have had a stroke and have a receptive or an expressive aphasia, as an example. So it's people who had prior traumatic brain injury. There's a whole range of folks who have had cognitive impairments, and frequently it's not in the record. So again, having people in the hospital, they're constantly working with the care management team to help self-identify cases is really important, and that's been more problematic since COVID-19. So we really do rely on the hospitals. But coming back to the community supports, we also get referrals from other community agencies who are aware they have people in the hospital. So, for instance, the Cleveland Clinic here has been a wonderful source of referrals, but so have first responders who know that they took Mary to the hospital, and Mary has had 5 visits in the last 3 weeks, and they think she's got a dementia. So first responders, other healthcare providers, other community agencies, all coming together in this network is really an important part of the identification process.
Great, thank you. Can you talk a little bit about, you mentioned the same DRG groups and different DRG groups, and there was a question that came in asking about were there certain diagnoses in those groups that you can talk to a little bit so we can understand a little bit more in depth about that issue?
Sure. You can be admitted as an admitting diagnosis for almost anything. So people come in for a gallbladder problem, as I mentioned, but people also come in with problems secondary to diabetes, problems secondary to coronary artery disease, and a whole range of other problems, chronic problems, that frequently are signals that there might be in a certain population a higher risk for a dementia. And so our in-hospital people are constantly looking for those people and talking to the nursing people to self-identify. And most of our testing of family caregivers and participants occurs after they're discharged. So it's really important to look for comorbidity issues as a vehicle for picking up people who are more at risk for the problem. And because we don't require a diagnosis, having people who are at higher risk and who are indicating by their behavior or from their family caregivers information that there might be a cognitive impairment, or the way we kind of laser in on them while they're in the hospital.
Great, thank you so much. All right, let's see. We could probably get to a few more questions here. Can you talk a little bit about how, if it's possible for participants to access the thoughtful hospitalization and thinking about seeking programs, and if so, where they can access those?
Great. We do them in the community, and we're happy to work, and I know folks at Cognitive Solutions would also be willing to share around the country. But what we do is we do them in libraries, in community settings. We used to do them very frequently in senior living communities. So we try to do them out where people congregate naturally in terms of the caregiver programs. The hospital programs, we try to use the education vehicles that individual hospitals have to create continuing education opportunities, and that's why we sometimes break them up into different chunks so they fit with a framework that an individual hospital has. So for instance, thinking about thinking, as I say, we've done it as a whole day, 8-hour seminar for one set of hospitals. Same program boiled down to a 3-hour half day. As a matter of fact, we did 2-3 half days on the same day for 2 other hospitals. So it's really important to be able to shape the educational programs to meet the environments of the hospitals so that you can get culture change and then do follow-up. And that requires an active relationship with the education team in the hospitals, for both physicians, I might add, and for the nursing and the other clinical staff.
Great, thank you. I think this might be our last question. Someone has asked about any barriers and we've talked about barriers at the hospital level, but have there been any barriers in the community to this approach in hospital to home that you've experienced, and how have you overcome any of those barriers or challenges?
One of the concerns, and again, having the stakeholder group is really important, is unless folks know you, and we think we're reasonably well known as a trusted not-for-profit in the community, but that doesn't mean everybody knows you. People are suspicious of your motives. So particularly people who've been burned by history. So we've tried to make really sure that we lay everything out, that we have transparency, that we really utilize the stakeholder concept. We put a lot up on our website. We invite folks in. We try to allow people to access cases and information, de-identified as frequently as we can. We put information out over the networks. So it's important that people understand that there aren't some unscrupulous motives here, that it's all done as a community service, and that we're not a stalking horse for some other kind of an initiative. And it's been successful. And this whole stakeholder reputation meeting has just really blossomed into that kind of broad-based comfort level for people who may not know about this initiative because they can talk to other folks who are stakeholders who have worked with us, who they trust.
Great. Thank you so much, Jeff. What an excellent presentation with fabulous information for the participants. We want to tell all the participants we really appreciate you joining us today at the National Alzheimer's and Dementia Resource Center webinar series. You can join us again for our next webinar on October 22nd, which will focus on how you might sustain programs for people living with dementia and their caregivers using billing systems for dementia services. The registration information for that webinar is available on the ASA website. I'll turn it back to Betsy for some final remarks, and I just want to thank you again, Jeff, for your great presentation. Betsy?
My pleasure.
Great, thank you so much. If you'd like to claim CEUs for today's web seminar, you'll receive a follow-up email by the end of the business day that will contain a link to the CEU application. That email will also contain a link to where you can download today's slides. Please note that you have 60 days to claim CEUs for this event, and it will take 30 days from the date of your submission in order for us to process and issue your CEUs. Thank you again, everyone. Thanks for joining us. Have a great rest of your day.